Right, hello everybody, and welcome back. We're into the poster session. Got three excellent young presenters with three excellent bits of data and stories to share. So I'm going to invite firstly Mo, who's a basic scientist from Chalk University and Hospital. My apologies for the pronunciation. And his poster is entitled Immune Phenotypical Analysis Between Pediatric Patients with Drug-Induced Liver Injury and Autoimmune Hepatitis. Over to you, John.
One moment. I think everyone can see my screen now, right?
Yep, we can see your screen.
Okay. Well, thank you. Good afternoon, everyone from sunny Istanbul. First of all, I would like to thank the organizers for giving us the opportunity to present our data. I'm a basic scientist, Mohammed Yüksel, and the title of my presentation is Immune Phenotypical Analysis between Pediatric Patients with Drug-Induced Liver Injury and Autoimmune Hepatitis. First, an introduction of both conditions. Idiopathic drug-induced liver injury is mediated by drugs such as antibiotics, NSAIDs, and biological agents, which then activate the immune system, which then damages the liver. Whereas in autoimmune hepatitis, there are autoreactive immune cells recognizing autoantigens and this way damaging the liver. DILI can present as an acute liver injury or failure, whereas autoimmune hepatitis can be acute, chronic, or acute on chronic. In both conditions, females are predisposed to get this disease, and the vast majority of both conditions will have autoantibodies in their serum. And in autoimmune hepatitis, again, most of the patients will have higher IgG levels, whereas DILI patients may have higher IgG levels in up to 50% of cases. Now, pertaining to the liver histology, interface hepatitis, which is actually a hallmark of AIH, is also present in DILI in up to, well, all patients actually, depending whether you are talking about a hepatitic DILI or cholestatic DILI. And plasma cell infiltration as well as eosinophils can be found within the livers in both conditions, though with a different proportion. I think the biggest difference between the two conditions is how we manage the liver disease. For DILI, it will ameliorate following the cessation of the causative drug, whereas for autoimmune hepatitis, the best management is to start with immunosuppression as soon as possible. Regarding the immunopathophysiology, well, for autoimmune hepatitis, it is actually established that within the liver, there are autoreactive T cells with a Th1, a Th17 phenotype, which then recognize autoantigens and damage the hepatocytes. And this is actually facilitated by Tregs with an impaired immunoregulatory function. Furthermore, AIH is strongly associated with MHC class II molecules, such as HLA-DR3 and so on. Well, for DILI, most of the liver immune knowledge comes actually from mouse models, which I think do not really truly represent idiopathic DILI. However, the data I found, they said cytokines are very important, and this way inducing hepatocyte apoptosis. Tregs may be involved, and for a particular antibiotic, MHC class 1, there is association with MHC class 1 for a particular antibiotic. So there are comparative histological and serological data among the two conditions. However, the biggest problem is that the immune phenotype differentiating DILI from AIH, if any, is actually rather elusive. So to that, and we have recruited DILI and AIH patients after ethical approval and obtaining written informed consent, of course. During a diagnostic liver biopsy, we have collected intrahepatic lymphocytes by fine needle aspiration. And those immune cells were then stayed with T and B cell markers and run through a flow cytometer. and this flow data was analyzed by FlowJo. Sorry. So the demographics, well, 3 in each group. DILI patients, there was 1 female and 2 male patients, whereas in AIH there were 2 female and 1 male patient. The DILI patients tended to be younger, however, their liver damage seemed to be exacerbated compared to the AIH group, though not reaching a significant difference. Then regarding the intrahepatic lymphocyte population, to start with CD8 cells, well, we didn't see any difference between livers from DILI versus AIH. However, there was a clear trend, let's say, of increased CD4 cells within the livers of autoimmune hepatitis patients as compared to DILI. And these are then representative FACS dot plots. Next, we have also investigated B cells, expressing or defined as CD19, CD20 double positive, and there wasn't any difference, no trend among the disease groups. However, there was a slight increase, let's say, of CD56 positive NK cells within the livers of DILI in comparison to AIH livers. Then we have also investigated immunoregulatory T and B cells, to start with the Tregs defined as CD4 positive, CD25 positive cells, which we then further gated onto FOXP3 positive cells, yet not expressing CD127. And well, there wasn't any difference between the two conditions. Then we also investigated Bregs, expressing again the B cell markers, obviously, but then expressing high levels of CD36 and CD24. And we found that there was a clear trend, again, not significant, of more Bregs in DILI patients compared to AIH. And again, this is all liver data. So, well, yeah, then regarding the outcome, well, autoimmune hepatitis patients, they are under immunosuppressive treatment, as they should be. And for DILI, we had a full recovery of all our 3 patients after stopping the hepatotoxic drug. And so they didn't require any liver transplantation. So I would like to conclude actually that this was the first pilot data demonstrating the distribution of intrahepatic lymphocytes in pediatric DILI patients and AIH patients. While the clinical and immunological picture was rather similar, though I would like to emphasize that the proportion of CD4 cells tended to be enriched, not significantly, in AIH patients, and Bregs and NK cells seem to be higher in DILI. However, further multi-center research is necessary with a much bigger sample size, as both conditions are extremely rare. So this was then my last slide. I would like to thank Koç University and the Turkish Association for the Study of the Liver for their contribution to this project. And again, this project wouldn't be possible without the endeavors of interventional radiologists and our research team headed by Professor Chidem Erikan. And thank you so much for your attention.
Thank you, Mohammed. That was a really, really beautiful presentation to get us kicked off. So this poster is now open to the floor for questions, and maybe I'll take the chairman's prerogative by asking the first question. So I noticed you've got your autoimmune and then your drug-induced, and you've done fine needle aspiration, which is fantastic, and that's very brave. Do you have the control of what's happening in the peripheral blood? And do you have like a normal control of patients? I know that must be quite difficult to consent for, but just fine needle aspirate on patients who are normal?
Well, so yes, we do. For your first question, whether we have information from the periphery, so PBMCs, actually we do have, and I didn't include this because first of all, it's a similar picture, but all tendencies were much smaller. So the biggest differences we found within the liver. So showing actually that if you look into the liver, the picture is more exacerbated, it's more clear than the periphery. Obviously, the periphery is just gives a general idea and wasn't that much informative. Now, regarding whether we have fine needle aspiration of undiseased, what we do have is obviously it's a liver transplantation center, and in Turkey, the vast majority of the donors are living-related donors. So we do have some fine needle aspiration as well as homogeneity from those livers, and we are still analyzing them. Hopefully, I can present that data in Vienna, where we have our manuscript accepted, where we actually have a kind of proof of principle of fine needle aspiration in pediatric liver diseases, kind of similar results as Upka et al. From University of London.
Very nice. That will be a very nice study. I'm looking forward to that. Are there any more questions from the audience? And if not, and maybe while anybody's thinking of another question, I can ask the second presenter, Chigda, if you would be happy to upload your presentation. Chigda's an internal medical resident from Ankara. So Mohammed, just while we're loading up the next presentation, how do you see this field playing out? What's going to be the next big story in this space? Because it's clearly very exciting. We all want to differentiate autoimmune from drug-induced. So what's the next story?
Well, I think until now, we always were limited with the blood or histology sections. This is really a limitation. So with fine needle aspiration, well, the advantage of liver biopsy is, well, liver biopsies are usually too small. Well, the vast majority goes to histopathology. Definitely, one cannot negotiate about that because it's primary for the care of the patient. So with fine needle aspiration, you do get sufficient amount of immune cells. To give a number, if you are lucky, 100,000. Well, if you use a multicolor flow cytometer, that's not too bad. It's not a lot like blood, where you get millions and millions. But if you can adjust the protocol, then that's really workable. And here I present only Tregs, but actually one can go further, like activation markers of Tregs and Sakaguchi Tregs and so on. So this is then the next step for the future, actually. And again, I have some data unpublished yet during that Vienna conference.
Cool. And do you think there's enough sample there to do single-cell RNA sequencing or CyTOF?
Actually, there is now one being hooked up in our lab, and the responsible lady said one should have at least 1,000 cells if you have a pure population. Now, if you use CD3 cells, then why not? That's quite a lot. But then if you really want to specifically investigate activated Tregs, for instance, then that's getting a bit tricky. And so we haven't done it, and I'm not sure how well that will go. But in theory, yes, it should be workable. And it is better than liver biopsy because the viability is higher. You know, in liver tissue, one needs to homogenize, and you actually activate the immune cells, which then is an additional variable as opposed to blood, where you don't need any activation and you just cycle and you have your cells clean there. So that's then another advantage. But we are thinking about it, though it's very expensive. Even in dollars, it's very expensive, so let alone in Turkish lira.
Very good. We could talk for ages because there's loads of very fascinating scientific offshoots from that discussion, but let's keep moving with the program. And thank you so much for your presentation again. And I think we already have Chigdem's presentation, so we're going to upload that from our side. And I'll invite her to present her poster, which is, I think, voriconazole-induced DILI presenting as intrahepatic sclerosing cholangitis. Thank you, Chigdem.
Hello, I am Çiğdem Kara. I am a resident of Internal Medicine Department at Hacettepe University. Today I will present a case that developed intrahepatic sclerosing cholangitis after the use of voriconazole, which we followed in our clinic. Voriconazole-induced DILI presenting as intrahepatic sclerosing cholangitis. Drug-induced liver injury DILI, the most common cause of toxic hepatitis. DILI has a wide clinical spectrum ranging from mild liver enzyme elevation, acute liver failure, cirrhosis, hepatosteatosis, sinusoidal occlusion syndrome, sclerosing cholangitis. Resistance medications may develop due to herbal and food supplements. Antifungal drugs are involved in about 3% of all daily cases, most commonly with ketoconazole, fluconazole, voriconazole, and terbinafine. Here we report a case of intrahepatic sclerosing cholangitis developed as a result of voriconazole use. Here I want to present our case. 51 years old male. He appeared to emergency department by the complaints of dyspnea and dysuria. Past medical history was significant in coronary artery disease, bladder and prostate cancer, but not any liver disease. Smoking 5 packet years, no alcohol confusion, surgery radical cystoprostatectomy, drugs metoprolol 50 milligram per day. In this table, we see the laboratory results of our patient. Acute phase are increased and leukocytosis is present. We see that there are plenty of leukocytes in urine analysis, serologically immunized for hepatitis B and hepatitis A. And for the dyspnea evaluation, we ordered thorax CT angiography. Thorax CT revealed that embolism involving both main pulmonary arteries. 17 millimeter cavitary nodule in the posterior segment of the upper lobe on the right lung. Patient progressed ertapenem was started for urinary system infection. Positive aspergillus PCR from bronchoalveolar lavage, voriconazole was started against invasive pulmonary aspergillosis. On the 90 days of voriconazole treatment, all liver enzyme increased 5-fold. In this table, we see the increase in liver enzyme after the initiation of voriconazole. When all enzyme increased 5-fold, voriconazole treatment was stopped. Total bilirubin was high, albumin was low. INR and thrombocyte count were normal. R ratio was 0.6 in plain cholestatic liver injury. Several autoantibodies were strongly positive. Antinuclear antibody 1/160 with nuclear pattern positive. Anti-Saccharomyces cerevisiae antibodies 1/320 titer positive. Anti-liver kidney microsomal antibody positive. Anti-mitochondrial antibody was negative. Immunoglobulin G, M, and A were all at normal range. Magnetic resonance cholangiopancreatography, hepatomegaly and hepatosteatosis, decreased contrast extraction, suggesting hepatocyte function impairment, normal intra and extrahepatic biliartery. Differential diagnosis: septic liver injury, autoimmune hepatitis, drug-associated autoimmune hepatitis, or cholestatic liver. Patient progress voriconazole treatment was discontinued when all liver enzyme increased 5-fold. Amphotericin B and ursodeoxycholic acid was started. Strong autoantibody positivity necessitated liver biopsy for the differential autoimmune liver disease from the liver. Liver biopsy showed that proliferation, irregularity, and lymphocyte attack in the bile ducts at portal area, which were also created 7 positive. Higher 7/18, fibrosis score 2/6. These morphological findings reflect the chronic active hepatitis dominated by biliary pathology and so recommended to rule out primary sclerosing cholangitis or secondary cholangiopathy. However, the findings were not characteristic for autoimmune hepatitis. As you can see here, mixed inflammation, including polymorphonuclear leukocytosis in portal area. White arrow showed that ductular cholestasis. Black arrow showed that bile duct injury. Medium-sized bile duct has been preserved. There is no concentrated fibrosis around the small bile duct, but vascular degeneration and lymphocyte attack are observed in epithelium intercrum staining. This table, on the 25th day of amphotericin B treatment, amphotericin B was stopped. Voriconazole was reinitiated. Liver function test, volumes did not deteriorate. Patient was discharged with oral voriconazole treatment. Discussion: voriconazole triazole antifungal agent used in the treatment of prevention of Aspergillus and Candida infections trains asymptomatic sublimating elevation in aminotransferase 11 to 19%. But voriconazole discontinued due to elevated liver enzyme approximately 1%. In this case, strong autoantibody positive necessitated liver biopsy for the differentiating autoimmune liver disease from DILI. Biopsy findings were significant for primary sclerosing cholangitis or secondary cholangiopathy, but not characteristic for autoimmune hepatitis. Liver enzyme decreased after voriconazole discontinuation and initiation of UTCA. The reinitiation of voriconazole didn't cause deterioration in the liver enzymes. Secondary sclerosing cholangitis was described in a minority of patients acute cholestatic DILI. Most frequently identified with amoxicillin, sevoflurane, amiodarone, infliximab, 6-mercaptopurine, gabapentin, venlafaxine, atorvastatin. Here were the first time in the literature voriconazole-associated secondary intrahepatic sclerosing cholangitis is reported. Thank you for listening.
Again, that was a very, very beautifully presented case and very clear. So I'm going to open the poster up to the audience. And in the meantime, maybe I'll take Chairman's prerogative again, if that's okay, and just ask you a couple of questions. So 51-year-old guy with diagnosed with invasive pulmonary aspergillosis. I know his history of prostate cancer and all the rest of it, but do we have his immune profile? Was he immunosuppressed, for example? It seems quite a severe condition for somebody who's only 51. I don't know if you can hear my question or if you're back on. But the question was more around what was the kind of immune profile of this patient before he was started on the voriconazole. Okay, well, I think we might have lost our colleague. I don't know if the technical guys are able to put her back on. I can't see her on the... Oh, Chigdem, I think you might be muted. Can you hear us? We can see you, but we... Yes, we can hear you, but it's quite quiet.
I think it's better to move on. What do you think? Another presentation?
Yes, that's a shame, but we're sorry about that, Chigdem. We were looking forward to discussing your case, but maybe when the technical things are resolved.
Maybe back.
So the next and final poster then of this session is going to be presented by Ozan from Izmir, who's a gastroenterology fellow. And his presentation is entitled The 10-Year Results of Patients with Acute Hepatotoxicity Caused by Mushroom-Induced Poisoning from a Single Center. Ozan, over to you.
Can you hear me well?
Yes, we can hear you and we can see your slides.
Okay, hello. We changed the topic a little bit. I am Ozan Fatih Sarıkaya and I'm a fellow of gastroenterology at Akdoğan University School of Medicine, Izmir, Turkey. And I would like to thank for this opportunity given. I would like to present 10-year experience of mushroom-induced acute hepatotoxicity in a single center that we made in our center at Akdoğan University. There are approximately 200 poisonous varieties of mushrooms among the more than 7,000 species. More than 90 of cases of fatal poisoning are caused by Amanita phyloides or Amanita verna. A fatal outcome can follow the ingestion of a single mushroom because the toxin is one of the most potent and lethal in nature. Alpha-amatoxin is not inactivated by cooking, rapidly absorbed and inhibits production of messenger RNA and protein synthesis in hepatocytes. And the second toxin, phalloidin, is responsible for the severe gastroenteritis that precedes hepatic and central nervous system injury. There is a latent period for the first symptoms of 6 to 20 hours after ingestion of a mushroom, and hepatocellular jaundice and renal failure occur over the next 24 to 48 hours, and followed by confusion, delirium, and eventually coma by 72 hours. And the characteristic hepatic lesion is steatosis on pathology and zone 3 hepatic necrosis. So mushroom poisoning is quite common in Turkey and can lead to acute liver injury and even acute liver failure requiring liver transplantation. We aim to investigate the outcomes of the patients with acute hepatotoxicity due to mushroom poisoning in our cohort. We had 30 patients, 17 males, 13 females, who were hospitalized for mushroom-related acute hepatotoxicity between the years 2010 and 2019 were included in the study. Clinical and laboratory parameters were collected and mortality-related factors were investigated. The mean age was 50.4. The admission to the ICU after mushroom intake the mean value was 2.5 days and minimum 6 hours to maximum 8 days. The late admissions were due to referrals from other centers, as we are a referral center for liver transplantation. Length of stay at the hospital was mean 11.4 days. 4 patients had ALF and 2 on admission, 2 developed hepatic encephalopathy on follow-up, and 15 patients had acute liver injury, 14 on admission and 1 developed on follow-up. 9 patients had comorbidities such as diabetes and hypertension. 10 patients were using different kinds of drugs on the admission. Our lab findings, I can show you the graphs of liver function tests. The peak levels of AST and ALT were lower than the other studies, similar studies. It might be related to late referrals, as I mentioned before, to our center, as we are a referral center. The total bilirubin levels, the peak mean value was 4.92, and the peak level of creatinine was 1.24. And the lowest albumin levels of the patients was 3.25. The INR level, the mean level on admission was 1.75, and the peak level of INR was 2.29. 14 of patients had INR levels higher than 1.5 on admission, and 1 patient's INR progressed from 1 to 1.6 on follow-up. The basic electrolytes, such as sodium, potassium chloride, the main values were in normal range, all of them. The most common presented symptoms were nausea and vomiting, as 90%, 27 patients had them. The least common was jaundice, as 1 patient had jaundice. All patients were treated with IV and acetylcysteine, and additionally, plus N-acetylcysteine, 7 patients were treated with IV penicillin G, 6 patients with IV silibinin, and 2 patients with both penicillin G and IV silibinin. Plasmapheresis was applied in 8 patients, and among 4 patients who had ALF, 2 had urgent LT, and 1 of them died in 72 days after LT. And 1 patient died due to acute liver failure, and 1 patient with acute liver failure improved with medical therapy and plasmapheresis. So in total, 3 patients died. Our mortality rate was 10%. 1 patient after LT, 1 due to ALF in 24 hours, and 1 patient due to sudden intra-abdominal and intrahepatic hemorrhage, despite the normal INR levels. We calculated a prognostic index in multivariate analysis. Higher INR and lower chloride levels at presentation to the hospital were found to be statistically significant factors related to mortality and liver transplantation. So the predicting death or transplantation of this prognostic index is shown here on the graph. We found a sensitivity of 100% and the specificity of 96.2, and the area under curve is 0.981. We checked for the other parameters such as urea, calcium, phosphate, eosinophilia, the viral parameters, the autoimmune parameters, and they were not found to be related to mortality at all. And in conclusion, the mortality rate of mushroom-induced liver toxicity was 10%, found 10% in our cohort. A wide spectrum of mortality rates were reported before in similar studies. They were below, near below 10% to 43%. And high INR levels and hypochloremia at admission were related to liver transplantation or death, we found in our study. And also in our study, hypochloremia might be due to prolonged vomiting or renal impairment. 3 patients who had renal impairment had, 2 patients out of 3 had hypochloremia. And the patients with acute liver injury due to mushroom poisoning are more likely to have adverse outcomes when they have hypochloremia at admission and impaired INR during follow-up. So finally, it is really important to follow electrolyte imbalances and INR levels closely in the ICU with patients who have acute hepatitis caused by mushroom poisoning, and the prognostic index might be used as well. Thank you for listening.
Wonderful, Ozan. Very, very clear presentation and a very fascinating topic.
Thank you.
So we're just waiting for, again, I'll open the floor to questions. And whilst people are thinking of questions, I'm sure there's loads of questions, but I've got some questions if that's okay. So really from basic biology all the way up to the clinical. So in the context of acetaminophen, or what we call in the UK paracetamol-induced acute liver injury, stroke toxicity, stroke failure, the pathophysiological mechanism is driven by clearance from hepatocytes via CYP2C9 and then accumulation of p-benzoquinoamine. So you have basically a normal route to get rid of this toxin, and when that becomes saturated, you then develop these reactive oxygen species, which then called mitochondrial disruption and hepatocyte necrosis, etc., etc.
Yeah.
Now, in the context of this chemical structure, why? Because you're getting a very horrific level of injury, and if you're swallowing these things, they have to go through the GI tract, etc., etc.
Yeah.
What do we know? And you've mentioned a few things about transcription, but share us some more ideas about why this is actually happening pathologically.
It's a tough question for me, I think. Actually, maybe it's because of the protein synthesis in hepatocytes. So it blocks the synthesis. So and after that, and after also rapidly absorption of the toxin, and it's also cannot be inactivated by cooking. So I think the aggressive situation depends on this. Am I clear on the? I don't know about the answer, but
yeah, no, that's very interesting. So you think it's a protein translation suppression issue?
Yeah.
And I guess there must be some chemicals, and people must be looking at how to investigate that within a kind of an in vitro setup. So that's interesting. Okay, and then on the other end of the spectrum, the kind of clinical management. So you said all of these people get an acetylcysteine.
Yes.
Then what's your usual treatment? Did you do things like hypothermia, high volume plasma exchange?
No, not specific. We gave all the patients classic treatment with IV and acetylcysteine, and as I mentioned, 7 patients took IV penicillin G. I think no one knows why, because it's the clinician's decision to give the penicillin G, and also silibinin. The silibinin is have more, I think, how can I say that? Studies about this toxicity. So maybe it's better to give silibinin with an acetylcysteine, but it's unclear what to give and which is a better way.
Yeah, so that makes sense. And then I guess the final question I had is related to, so if you look at the data around what are the so-called, it's very difficult to have successful non-transplant based interventions in this cohort of patients, but the few things that seem to have worked, I'm thinking of high volume plasma exchange and recent trial from...
Also plasmapheresis, the patients, I think, let me check, the 8 patients had plasmapheresis.
Great. And did you see...
And no, I think only one of them died.
Really? That's it.
Plasmapheresis, yeah.
And in those patients...
I didn't put it in here, but I think one of them who went to liver transplantation and died 72 days later because of the liver transplantation complications such as cholangitis, etc., etc. But it's a really powerful to do plasmapheresis to the application.
And in those cases, did anybody look at the ammonia levels? Because that seems to be the one factor, and it's a very controversial area, but the ammonia levels do seem to predict mortality in this cohort, in my opinion.
Only, I think 16 or 17 patients had ammonia levels, so I didn't put it in here, so we didn't check for it.
Very good. Excellent.
We had missing data for the ammonia, so we didn't put it in here.
That could be your next cohort of patients that you follow up.
Yeah.
Next 10 years. That's
it's
good.
In our minds, yeah. Thank you.
Very good. Okay, well, I think we have a few questions from the participants. Meral, do you want me to read these out, or do you want to take them?
You can read. I can't see them.
Anyway, I can ask some question.
Sure.
Very nice study, Ozan. Just I want to ask you, did you check the lactate level?
Yeah.
Lactate level?
No, we didn't.
You didn't. And
few patients had lactate levels, but as our study started from 2010, and at that year, and beginning from 2010, the lactate levels weren't that much important than today. So only, I think, a few patients had lactate levels.
Yeah. There are some questions in the audience. The first one is Professor Ramazan Edelman, and he asked, did you check the distribution of lymphocyte in the blood?
Yeah, we did that, but no significant difference was found.
Okay, and also from Mijdat, do you use active Churchill on interfere with enterohepatic cycle?
Charcoal, we did not know that because most of the patients were referred to our hospital, and I think 10 of them had charcoal treatment before they referred to us. So it's unclear. Because most of the patients came from the countryside and local hospitals, they referred to us. So we don't clearly know what they did there.
And another question from Ali Aldahemi. Is there any evidence for N-acetylcysteine on silibin in mushroom poisoning? And also N-acetylcysteine for DILI? Maybe you can say something.
Sorry, can you repeat, please?
N-acetylcysteine using or silibin using in mushroom poisoning. Is there any effects? What do you think?
Yeah, I mentioned it is the silibinin, mostly silibinin, was showed very I'm sorry, let me check the silibinin slide of mine. Yeah, there are lots of can you hear me?
Yeah.
I'm sorry.
It's okay.
Yeah, there are lots of studies about silibinin, and it was shown to be useful. But the N-acetylcysteine, some studies showed to be useful, and some of them not. So we give it anyway.
And you know that especially acute liver failure due to mushroom poisoning, it's difficult to decide when to transplant or wait. I mean, it's really very difficult. And in the literature also, there is no very good data about this because very few cases.
Sure.
What do you think, I mean, in your center, if the patient comes there, how to follow up?
I would like to give an example. Yesterday we had a patient. It was not mushroom poisoning. It was, I think it was because of the carbamazepine toxicity, and the patient was also referred to our clinic. So we start we first start the close follow-up. We refer them in the ICU unit, and then close follow-up, and also we follow the patient's mental situation very, very closely. The mental impairment, we check it, and also the INR levels, and we mostly follow these two, the INR levels, and if the patient is in hepatic encephalopathy or not. So we prepare for the liver transplantation if the patient's results are going high, and if the patient has hepatic encephalopathy on the admission. So we ask for consultations to the psychiatry, and to if the patient is a woman, sometimes to gynecology and chest disease and pulmonology and cardiology. So we prepare for the situation, and we check for the patient's relatives if there is a vital transplant recipient, giver, I'm sorry. So if not, we start the procedure, and for the follow-up, if it goes bad, we start it and we make the liver transplantation. It's a really complicated situation.
So we have to follow up in the transplant center this patient.
Sorry?
We have to follow up this patient in the transplant center.
Yeah, sure. So we have a lot of referrals to our center.
And I don't know, Çiğdem is here. Fulya asking question, but Çiğdem, I think, doesn't hear. Did you?
I am here.
You are here, okay, Çiğdem. Dr. Fulya asked you, how can you explain the normal liver test after reuse of vancomycin?
Can you repeat me?
How can you explain the normal liver test after reuse of voriconazole?
2 weeks inpatient visiting, and the patient discharged. We come to visiting this week. The patient's liver function test is normal.
And also, did you check the patient have IBD? I mean, in this patient, inflammatory bowel disease, maybe?
This patient, no. No. Thank you.
Okay. Tamir, any question?
No, I think it was a very wonderful session. I think all three presenters did very, very well.
Okay. I think we have to finish now because already time's left. Thank you very much, all presenters. Also, thank you very much, Tamir.
Thank you too.
Thanks, everybody. Lovely to meet you all. Hope to meet in person next time.
Thank you.
Thank you.